Another podium that I can't see over. That's okay. At least you can hear me, right? That's the point. When you get the cheap seats at a concert, you have to say it's acoustic, it's acoustic. Okay. So I was invited to speak about the penetration aspiration scale today, and am happy to be doing so. I appreciate the invitation from the committee for this meeting. It's a great committee. I think they put a great program together. I want to disclose a couple of relationships, and if anybody wants to talk with me about this later, that's fine. Swallow Solutions and Bracco. Bracco does diagnostic imaging. I do want to say that we have the patent on the very bar products that have been discussed this morning. I want to tell you I had nothing to do with the puddings, Louis Racome, only the fluids. So there you go. All right, that's disclosure at its best. So aspiration, you know, is the passage of foreign material into the airway. And aspiration has effects on health, which is clearly the hottest topic right now in Medicare and medical care, or so it seems, as well as policy in this country. Health effects related to aspiration consider the amount that's aspirated of foreign material, the depth, how far into the airway does foreign material go, and then the sensory motor response to that material. Is the patient sensing the invasion, and what is if there is any response? We all know about silent aspirators, and we know that then the health effects likely are worse on silent aspirators than those who sense it and might make an effort at least to expel the material. Right now we know that there are too many bounce backs into the hospital. Patients are discharged and they come back in within 30 days, and Medicare is definitely putting its plan in place now to penalize hospitals or institutions that according to number of bounce backs. So I think we have an opportunity to play a very big role in our institutions now in cost savings to show them how we can think in novel ways and take care of this problem with the administration. Historically, aspiration has been coded with notations that we're all familiar with. First, binary, yes or no. Does aspiration occur, does it not? Then we got a little bit more precise, thanks to Dr. Logeman, as far as I know, who defined it's important to know when during the swallow aspiration occurs, before, during, or after the swallow, because that tells us to look further at specific physiology related to the timing of the aspiration. And then the estimate, people try to estimate, oddly enough, from a two-dimensional image, the amount of total bolus that is aspirated. So if you're doing that, I suggest you get good reliability among your own staff in terms of that being some sort of a meaningful outcome. Aspirations received a lot of attention. It's probably the most clinically significant issue in terms of what we just talked about, health status. But we learned over time, although Netter seems to have known before us, that penetration was also an issue. This is an old Netter slide, and you can see that he drew the anatomy with a small amount of that ugly yellow bolus headed toward the glottis. And this would be an image of penetration, which is material heading toward the airway but not going below the true vocal folds. So in the 1990s, I do want to say I'm here talking about old work that we've done. We did create a tool, and there are 3 manuscripts out there. I have 15 minutes. I've probably already used at least 3 of them. So in the next 12 minutes, I'll tell you what I can without being the FedEx commercial on TV speaking as fast as he does. And we have 3 published articles. I want you to see in this slide that we have a team that was consistent in this effort. And Jay Rosenbeck and I, and Jim Coyle, I believe, are the team that consistently hung together and created the questions, the hypotheses, the designs to test them. and disseminate the material. And that's important. If you're really going to go after a hypothesis, if you're going to get the evidence, it's important to pursue it beyond perhaps just scratching the surface, but to make the material as useful as possible. Please feel free to look at these articles at any time, and I must say I feel very confident up here because Lou Beck in the VA always says, "She or he who hath data can speak softly." So here we are. The penetration aspiration scale was developed to provide reliable quantification of selected penetration and aspiration events during the video fluoroscopic swallow study. We wanted to create in our group in Madison, and that would be at that time Jim and Jay and I. You had to have a J in your name to be part of the group. We were interested in creating a tool that would help us through a number of projects and better patient care. So the tool that we developed, we decided, needed to document various aspects of airway invasion. The depth of bolus traveling into the airway was one parameter. The patient's response to the penetration or aspiration, to learn a little bit about sensory motor integrity, and residue or clearance. How much is left in there when you turn off that you know can be part of health status because you're not clear on where it's going or what it's doing. You can't have fluoro on for very long at all. The penetration aspiration scale is scored on the entire swallow event for a bolus. It's not just about the moment of aspiration. And we looked at fluoros. We thought of our patients because we are clinical at heart and clinical in practice while we do our research. And we came up with a number of items that we thought described many fluoroscopic studies we looked at, and came up with what at that time was a 9-point scale, and over time was reduced to an 8-point scale that is used in practice by a number of different clinicians out there. Marta's shaking her head, and I'm sure there are other people here who I've worked with and have had the pleasure of communicating with in a way that's much more meaningful using these numbers with operational definitions that we all share and understand. In order to, what shall we say, standardize, make the penetration aspiration scale useful to the greater group, we used fluoroscopy, and I know earlier we heard you have to have a standardized protocol. Kathy Lazarus was passionate in her closing moment. Standardized protocols are important. And so we actually looked at patients and standardized fluoroscopy in our examination of them. Each one had 5 thin liquid swallows. We initiated fluoroscopy on, which we tell the radiologist on, before swallowing started, and we tell the radiologist off after the swallow is completed, which we operationally defined at the time as hyoid return to rest. And we had 4 judges, producing, our vision was to produce a ranked scale of goodness. So we wanted this scale to describe all penetration and aspiration events. We began with a score of what normal we thought was, and that would be a score of 1. A normal swallow has no airway invasion. There's no contrast that enters the airway. And here on your left, you see a fluoroscopic image, and on your right, you see the line drawing that emphasizes this. Now, I do have the video fluoroscopic images of each swallow as well. I'm not sure I'm going to have time to show you each of these, but you can see how normal is. It's fast and it's clean and it's beautiful. And that's as normal gets. Let's see, I go outside to click forward. Our first publication then was to take this scale we had developed and to assess its reliability, ensure its reliability to make it useful to our colleagues. So we had 15 dysphagic multiple stroke subjects provide 75 swallows, and we had the 4 trained experienced SLPs serve as judges, and they reviewed the fluoroscopic images for one time or at baseline, and then again for reliability purposes 2 weeks later. So there was a time in between. They were clearly blinded in that 2 weeks in terms of who they were looking at again. And the findings of that study, our first publication, was that interclass correlation coefficient, well, inter and intrajudge correlation coefficients were good. We were excited. And the interjudge approximates intrajudge agreement. So this was good news for this scale. Then Gary McCullough, are you here, Gary? Gary McCullough jumped into the picture. Hello, not here today. I guess he'll be here tomorrow. Was young at the time, we're all a little older, and he was just, I think, getting his PhD and came to Madison. And he had been very excited about this tool and went back, I think, to Nashville, perhaps. He was interested in if the scale was ordinal or interval, how do we say that? If it was an interval scale or an ordinal scale. And that is each score from 2 to 8, 1 was normal, is assumed a more severe sign of dysphagia, Bronwyn's sign of dysphagia, than behavior identified by the preceding score. And so number 2 on the scale, for instance, is a contrast. The contrast enters the airway, remains above the vocal fold. So now you have contrast in the airway. It's more severe than 1 because it got in there, but there is no residue. It is ejected by the swallow. That's number 2. And here's what number 2 looks like. You have a little bit of penetration, right? But after the swallow, there's nothing there. It's cleared, okay? So that's a number 2. But the PEN-ASP scale does not quantify all swallow events. You need to know that. We didn't go into this deluding ourselves that we were making a tool that was going to be useful for all of swallowing, screening, and evaluation, diagnosis, et cetera. Of course not. The PEN-ASP scale doesn't quantify all swallow events. This tool has been constructed with the framework that you as clinicians use other systems to specify amount and timing of penetration and aspiration events and other events that are important in swallowing in addition to airway invasion and the response to airway invasion and bolus response, which is what this scale is about. The traditional signs of dysphagia remain critical. They are temporal, spatial, clearance, and the number of swallows, the repeat swallows they've been talked about this morning. But the PEN-ASP scale is offered as one tool to be included as a part of a total swallowing assessment or battery. The penetration aspiration scale offers advantages to clinicians and researchers, and that they differentiates normal and abnormal swallows, differentially diagnoses some swallowing impaired populations, can be used as an outcome tool for clinical trials. You're all talking the same language. It can be used to determine why some patients get sick and some do not. And what I love about it is it demonstrates functional change in an individual patient. So your patient, we talked about video fluoroscopy this morning, and my way, I do it this way. You can do a fluoroscopy, your patient can swallow the 5 milliliters of thin liquid and can get a 7 on the PEN-ASP scale when you start up your evaluation, which means it does enter the airway, it is aspirated, but they can eject it. During that same evaluation, and you can put this in your report, you perhaps tried a chin tuck and you moved that patient from a 7 to a 3 perhaps, which means that they still got material in the airway, but it was only penetration. It wasn't all ejected, but they moved aspiration to penetration that had residue. This is the kind of information you have a score, a 7 to a 3, in one video fluoroscopic swallow setting where you have now quantifiable information, not just about the swallow of this dysphagic patient, but about the effectiveness, the outcome of your intervention. So it's very, very useful, and in terms of what Medicare likes to see, this is good. If you see a patient for a number of weeks, and perhaps you're doing a strengthening regimen, and when you begin, that person is scoring, let's say, a 7, and is penetrating, is aspirating and ejecting. And maybe the second week of strengthening, you move that patient to a 6, and maybe by the 7th or 8th week of the strengthening, that person is a 2. And we have these data. We have evidence for our treatment from this scale and from other methods that we use. Is the penetration aspiration scale ordinal or interval? If it was both, it could be used as a severity measure for dysphagia. I don't have much time. As I said, these materials, these are published data, but it appears that our scale progresses from least severe, no penetration or aspiration, to most severe, aspiration with no effort to expel. I'm not going to spend a lot of time on this part. I would like you to read it at your leisure, because we all have so much leisure. But the third manuscript, we wanted to define the distribution of the PEN-ASP scale scores in normal people, and we had 98 subjects, and then in stroke patients and head and neck cancer. The question is, can it identify airway invasion that changes over age groups that are normal, healthy people? And are those numbers scored different from dysphagic patients? And are dysphagic patients with different etiologies, particularly stroke and head and neck cancer, different from each other? So remember, we're looking at the depth to which material passes in the airway and the success in expulsion and the clearance. I'm moving forward quickly. What we learned is that healthy subjects, in fact, don't just score a 1. It is healthy to get a 2 or a 3, to penetrate and not even expectorate or get rid of what does penetrate. And this occurs more frequently as you get older. We found that more penetration also occurred on the later swallows. So our older folks may have only had a 1 on their first swallow, their second swallow, maybe a 2 on the third. By the 5th swallow, not only did they get a 3, but we had a patient who is older. Let's find that guy. Where are you? Who didn't just get a 3, but he got a 7. So he's an outlier in the normal group of 95. But older people, we know, fatigue. They don't have the endurance, and we need a lot more data to have normative data. People think 95 is a lot. It's minimal if you look at the psychology kinds of studies that are done in other fields. In our field, we don't get the numbers we need to really have the power we need. So one of the findings is age increases airway invasion, particularly on repeated swallows, not the first swallow. And then our head and neck cancer and our stroke subjects differentiated themselves. Our healthy patients, as you could see, had many more normal 0s or 1s than our stroke and our head and neck cancer patients, who differed among themselves. And the interesting thing is it was only the stroke group that actually got 8s aspirated and didn't sense it. Head and neck cancer patients do aspirate much less frequently, though, in this group at least, than our stroke patients. And there's some wonderful stuff to think about. Our stroke subjects had more episodes of and deeper airway invasion than head and neck cancer patients. Scores of 8 were only in the stroke patients. And I want to conclude without showing you pictures, but to say there's variability on the first 2 swallows in dysphagic groups beyond the variability in normals. A characteristic of abnormal or pathologic behavior is change in variability. We saw it here with this tool. Can we profile abnormal swallowing groups? I think we can. I think we got the initial data on small numbers, and there's a lot more to be done with this tool. Before I sit down, which I'm overdue to do, I do want to emphasize that this is one tool to be used in a battery of tools. We're not telling you any temporal spatial information you need to know in order to target the therapy that you're going to use, but we are giving you a quantifiable tool that gives you evidence of progress, and if it's used well, it could make a difference even in policy setting. So thank you all for your attention.
Good morning. Thank you for the invitation to be here. My topic this session is the utility of objective measures from fluoroscopic swallow studies. For the entire time that we have been doing fluoro studies, we of course note subjective impressions from them, and I've listed here ones that I think are particularly useful. But for almost the same amount of time, we've attempted to extract objective measures of timing and displacement from our studies. Why did we do that? Well, initially, it was because we had great concerns about our team's lack of agreement on our subjective observations. We also thought if we began to focus on biomechanical events, and in particular on impaired biomechanics, that would help us direct our treatments more precisely. And of course, we understood that we were exposing patients to an invasive procedure. We wanted to be sure that we were maximizing the potential of the study, getting as much information from it as we possibly could. I don't think we really understood this at the time, but we also found out once we began to measure biomechanical events from swallowing, it is in fact an excellent way to learn about swallowing. Once we decided to pursue this course, we needed to develop strategies for timing and displacement measures. We collected normative data. This time we have a relatively large amount of normative data on carefully screened adults, non-dysphagic, under and over the age of 65. We considered validity of the measures we were attempting to get. We looked at what other investigators had said and reported. We established reliability across 4 judges on our normative data, and assessing reliability has been a continual process thereafter. We do it periodically clinically, certainly every time we add a new clinician. Every time we use any of these data for a research project, we again assess reliability. I'm going to tell you just a little bit about the measures that we get. First of all, timing, and one of the things that we do that I think is a little bit different from what other investigators have done is we track bolus transit times separately from swallow gesture times. So as I show you this clip and you see the B labels, those refer to where the bolus is at a particular point in time. The other labels tell you about swallow gesture times. For example, when the hyoid is maximally displaced or when the PES is maximally opened. The benefit of that is then it lets you look at the coordination between bolus transit and swallow gestures. And sometimes, in fact, that may be the most aberrant feature about a study. All of our measures of maximum displacement are referenced to the position of the structures with a 1 cc bolus held in the oral cavity. It's sort of a pseudo-rest position. Almost everyone can hold a 1 cc bolus in the oral cavity. Structures are stable and not moving at that time, so it's easily replicable across patients, across populations, across trials. We also, as you can see, put a ring of known diameter in the mid-chin, in the lateral view, in the mid-neck, in the AP view, and that, of course, allows us to convert pixels to centimeters later. The measures that we get, the first displacement measure is hyoid to larynx. To find that measure, we first identify the position of the hyoid, again, with the 1 cc bolus held in the oral cavity. We measure that down to the bottom of the larynx, which we actually define as the top of the tracheal air column because it's quite easy to identify. We would then go through the study and any subsequent study and find the point where those 2 structures are maximally approximated. As you see there, measure that difference. We then look at the difference between those 2 measures, and that constitutes our hyoid to larynx displacement. Another measure we get is referred to as the pharyngeal constriction ratio. This is a simple measure. We simply outline the pharynx, the pharyngeal airspace, with a 1 cc bolus held in the oral cavity. And this looks pretty simple, but we're doing it according to a very prescribed convention that we use. Calculate that in centimeters squared. We then, again, for any subsequent study, find the point where the pharynx is maximally constricted and, again, measure that area. And in a normal swallow, you should not see any pharyngeal airspace. You may see a little bit of residue there. We then look at the ratio of these, the pharyngeal area max to the pharyngeal area hold, and that is the pharyngeal constriction ratio. Another measure we make, the maximum opening of the pharyngoesophageal segment. We make this measure in both the lateral and the AP views. What we do is find the narrowest point, typically between C4 and C6, when that area is maximally distended during the swallow. When you identify this point, and this fellow has a little bit of a cricopharyngeal bar, which makes it easier to spot, then you're very careful to try to measure the lumen and not touch the adjacent tissues. And as I said, we also get that measure in the AP view. The final displacement measure we get is maximum displacement of the hyoid. To make that measure, we first, again, find the position of the hyoid with the 1 cc bolus in the oral cavity. We outline the hyoid. We also extend a vertical line between C2 and C4. We will then go through, again, any subsequent swallow, find the point where the hyoid is maximally displaced anteriorly and superiorly. We don't attempt to track the hyoid or to divide it into anterior and superior components, but at that point we would again outline the hyoid maximally displaced and extend a line along C2 to C4 again. And you can see that the patient's head is moved, so those lines don't line up. So then we need to overlay those images, rotate them, as you see here, so that the vertical lines line up. And then we simply measure the distance between the hold and the maximally displaced position. That's our maximum hyoid displacement. How do we use the data? Well, obviously having the normative referent has been very useful. It's allowed us to elucidate some differences in normal or typical swallowing associated with aging. The data, of course, also allow us to compare an individual patient to age and gender-matched normal subjects and to track individual patients with time and/or treatment. The data, of course, also permit comparisons of patient populations to each other and/or to normal subjects. Another way we use the data, we have found that they inform our treatments, and I think it doesn't matter whether it's behavioral, medical, or surgical. Sometimes these data have a lot to offer us, and I'm just going to tell you about one example here. On the right, you see a patient at the top who has, again, a small cricopharyngeal bar. If we measure PES opening in this individual and we find it's reduced in the lateral view, but it's within 1 to 2 standard deviations, and we measure it in the AP view and it's normal, we're probably going to be fairly conservative. We might recommend diet modifications, maybe Shakir exercises, depending on the patient, maybe dilation. We might want to do manometry in this patient. On the other hand, and if you look at the fellow down here with a more prominent cricopharyngeal bar, if we measure PES opening and it's more than 2 standard deviations below the mean in the lateral view, and we measure it in the AP view and it's also reduced, then we're going to be more aggressive. We would consider maybe dilation, maybe a myotomy. If PES is reduced and the pharyngeal constriction ratio is elevated, and or if the pharynx appears to be dilated, larger, even in the hold position, we will consider earlier, more invasive treatment. And our feeling about that is if you experience chronic or prolonged obstruction at the PS, eventually that may lead to pharyngeal dilation with possible weakness of the pharynx, and of course that would have implications for pharyngeal constriction and pharyngeal clearing. Another way we use the data, and we did not anticipate being able to do this initially, but now we use them to try to assess risk and potential in individual patients, and in fact I think we approach our entire evaluation, clinical and instrumental, of patients as really this, an assessment of this individual's ability to eat orally and also the risks for oral eating. And I think what you have to remember here, and we've heard a lot about this morning, even if you get the best fluoro study in the world, it provides a very brief sample of swallow function. If you can look at the study and get information from that study that allows you to anticipate or predict the likelihood of an adverse event, like aspiration, even if you don't see it happen during the study, but you suspect it may happen away from the fluoro study, then the study is going to be more powerful and the information is going to be more powerful. So for example, here's a way we might use these data. In the blue column here, you see Normative data for a 20 cc liquid bolus. These have been corrected for age and gender. You see the measures I've mentioned here on the left, and what you see in blue are means plus or minus 1 standard deviation for the normal subjects. Then we took a large number of patients. These were all adults, but all pathologies, and we divided them into those who did not aspirate and those who did aspirate. And very interestingly, for each of these variables, as you go from left to right, from normal to non-aspirators to aspirators, there is a general decline in function as you move in that direction. So then what we said was, okay, if a patient deviates more than a standard deviation from the normal mean, what are the odds of aspiration? And those are the data you see in the green. So now, if we see these kinds of values in an individual patient, even if we have not seen them aspirate during the study, we consider it might be a possibility away from the fluoro suite in real life, or at the very least, we consider that these are risk factors for aspiration. So objective measures, certainly they have allowed us to elaborate oral pharyngeal swallow mechanics, both normal and impaired. They provide us with objective, evidence-based treatment directions. They allow us to document, again, in an objective fashion, changes in patients over time and treatment. They allow us to compare differences across patient populations. They increasingly, we found, allow us to assess risk and potential for oral feeding in individual patients. And I feel pretty comfortable that we are trying to get as much information from this study as we possibly can. Of course, there are always questions. Initially, we considered the validity of these measures very carefully. Are we measuring something that's really an important event during swallowing? We have to agree on the measurement conventions, and assessing reliability is an ongoing process. You do not want to do it once and then forget about it. And of course, some important observations are not yet at least amenable to measurement on fluoro. So objective measures are really just one component of our fluoro assessment, just as the fluoro assessment is just one component of our overall evaluation of dysphagic patients. Thank you very much.
Myself and Sengman Wang came up together with a solution to the question. And so I'm going to present some very preliminary data that we jointly have put together to address the issue of how we can identify abnormalities in neural mechanisms from the MBS. So what might the MBS tell us? We certainly know about volitional initiation of swallowing, and we can identify that from the MBS. Sensory triggering seems to be one of the components in initiating swallowing, as well as the volitional initiation from the cortex. And then, of course, we know that there is a component of the brainstem central pattern generator in programming the swallowing. So this is a diagram of that conceptual concept of the central nervous system and how it controls swallowing. You have cortical initiation, which is stronger, particularly when we're in the MBS situation where we say swallow now to the patient. Clearly, they're probably using some cortical mechanism to initiate that. There is the bolus, the sensory input, down here as number 2. And that is having an input. We've already put the bolus in the mouth, and so there is a sensory input there as well. And then there is the central pattern generator that might be triggered both by the cortical input as well as the sensory input. We know that sensory input is bilateral. Even if you initiate sensory input on one side, you will have projection of that sensory input to both sides of the cortex. And so, although that may not be the initiating event in every case, it certainly can contribute to cortical initiation as well as brainstem patterning. So conceptually, we're talking about the nucleus tractus solitarius being the input to the ventral swallowing group, and that both cortical inputs and peripheral inputs drive this central pattern generator. So what can we study about that model, excuse me, using MBS? And certainly people have measured timing. The onset of the pharyngeal phase, of course, is one aspect that people measure. The patterning of when they start to raise the hyoid and the larynx. And if I'm assuming central control that I want to measure, I'm going to assume that the peripheral system is intact and that the motor nerve and the structural system is intact. And I want to see whether I can study something about the central control at the cortex or the brainstem based on the measures from the MBS. So I'm borrowing in this presentation from studies of gait analysis that are used by biomedical engineering, and there's been a great deal of work in studying gait using measures of kinematics, that is the movement, the displacement over time of different structures. So there are phases of the gait cycle, and it starts initially with the impact of the heel on the surface, which is part of the sensory input to the walking system. And there is cortical initiation for the subject to move forwards, and there is also a pattern generator for walking. So there are some similarities in some ways to the gait cycle as there are to swallowing. You also have phases within the gait cycle, in the initiation of double support, then the right legs swing, and then double support followed by left wing swing. So you can divide up the gait cycle into different parts or components or patterns that is fairly invariant and can allow you to study that. And in fact, you can even look at when different muscles come on and during that gait cycle, and if you remember some of the work that we've seen in the past by Doty, where we showed the pattern of different muscles coming on in swallowing, you can see that there are some similarities between the gait cycle and swallowing. Well, Becky Leonard and colleagues have done wonderful work on swallowing, looking at different phases in swallowing and the invariant order of those phases. And here's a diagram from their data showing the different components of swallowing and how these follow in a relatively invariant sequence. So again, we have a cycle that if you look at the full swallow and all the events that occur, they can be sequenced. And here are some measures that they did from their patients and found that there could be a sequence of different components. And if you measure the duration, you can see that some components are longer than normal. In this patient in particular, the air closure cycle was much longer than it was in controls. Similarly, if you look at displacement, that is the amount of movement range that occurs, how many centimeters a structure moves, you can measure the patient relative to the normal data and determine whether the patient is moving to a lesser degree than normal or to a greater degree than normal and has more variance in certain components of the cycle. So we want to look at another aspect of that. Looking at the gait cycle, if you look at knee angle over time, you can see that the knee angle changes at different phases in the gait cycle. And so this gives you the displacement or the angle of movement over time, and you can look at how that is variant or invariant over time during a walking cycle. So taking that concept, we want to apply the same concept in our thinking of swallowing. Now, what people have found that there are, you can take means and standard deviations for the motion over time. So I just showed you knee angle. Here is angle of the ankle. You can also do the actual timing and power of the different motions that are occurring during gait cycle, and you can conceivably do the same thing during swallowing. So this is work that we did using a motion analysis system from the MBS. It's called Peak Motifs by Vicon. And you can track the position of structures over time, and your resolution is the time between the different frames in the video of the MBS, which of course is around 17 milliseconds. You can study the initiation of the cycle using a definition, and we decided that a definition would be relative to the bolus position because you don't want to do it relative to the movement of certain structures if the movement order of certain structures is affected. So for the onset, you could use the sensory-driven input because of the bolus, due to the bolus, and use that as your initiation. So the onset relative to the bolus position, say crossing the mandible, and then the offset relative to the bolus crossing the UES. And to be able to capture the full motion, we used 1 second before the onset of the bolus hitting the mandible and 1 second after the bolus left the UES. So this is the kind of analysis that we can do. I should mention that these trajectories are smoothed because the Peak Motifs system allows you to do low-pass filtering, and we found that 4 Hertz was particularly helpful in allowing us to look at the movement trajectories over time in a smooth fashion. So here you have the larynx in the elevation position, and here's my, okay. So here you have the larynx and the, in the Y position over 2 sequentials, 2 swallows at different times to look at how reliable this individual, who is a normal subject, is in their pattern of larynx elevation over time. You can also look at the elevation of the hyoid over time for 2 different swallows. You can look at the hyoid in the anterior position over 2 swallows and the larynx over the anterior position. So you can look at motions in elevation and motions in anterior to posterior over time in an individual, and you can see that this individual, using the same type of bolus, had a very reliable pattern of their swallowing. The second individual was much more irregular in some way in the timing of when their peaks occurred and when their onsets occurred, both for laryngeal elevation as well as for hyoid, and the anterior position was particularly different. Now, one thing that they do in looking at gait cycle and the patterning and how regular the central pattern is they normalize the time of the cycle. And so here is a gait cycle where they've taken the onset of the footfall and the onset of the next footfall and used that as 0 and 100%. So you're squeezing everything into the same time. And remember, we're using our onset at the bolus at a certain arrival at the mandible. And so you can use that as plus 1 second before that, using that as your 0%. So here we've done, this is the trajectories of the hyoid and the larynx in the anterior position in 4 different subjects over time. And then when you normalize and put the time all from 0 to 100%, you can see that you get a much more regular patterning between different normals for the anterior position of the hyoid. So this is displacement over time, and you can see that the peaks line up very closely when you normalize on time. The larynx in the anterior position, of course, is much smaller movement and differed much more between individuals, both in amplitude and in the timing of that occurring. And clearly you could normalize based on the different lengths of the spine and the difference between the different vertebrae, as Katrina Skeel has done in some of her work. But if you look at normalization over time, you can see then that these peaks line up much more closely, and so there isn't such a difference in the timing of the pattern when you normalize. So the questions we wanted to consider is, first of all, we think that the elevation of the larynx is somewhat dependent on the motion of the hyoid, and so you could look at these two displacement patterns over time and determine that. We also wanted to examine if there's a consistent relationship among normals, and whether there is relative patterning of timing between the hyoid and the larynx, because this would tell us something about the biomechanics of how movement of one structure might be confined or dependent on another. Finally, you can use the first derivative, the velocity tracing. As it leaves zero, you can identify movement onset in a fairly objective fashion. And in this way, we could look at whether the central pattern generator is similar across normal, healthy subjects. So this is very preliminary data on this question. These are velocity trajectories, and you can see.
I want to thank Dr. Belawski and the wonderful planning committee. You've done a gorgeous job with this meeting. It's a privilege to be up here with this faculty today. I'd also like to acknowledge, like I do every time I talk on this topic, my mentor, Dr. Jerry Logeman. If it weren't for her, I wouldn't be here. She is a physiologist and trained me as a physiologist. And I think you'll see that in my work. And Kathy, my eyes have never been the same since our doctoral time staring at those videos. So, inside joke if you weren't here earlier. The Modified Barium Swallow Impairment Profile. Well, these are our support and disclosures, and I'm very proud to disclose them. I'm very grateful for support. Unless you're independently wealthy, you can't really do science. You do need help, and the NIDCD has been fabulous at supporting my work over the years, so thank you. Competitive grants, but thank you nonetheless. And the other disclosures are up there as well. And the one in pink is the one that really led to the work I'm going to try and summarize in 15 minutes, 10 years and 15 minutes. The motivation for doing the MBS Iymp, you heard a lot of talk this morning about the problems that we face with reliability, with standardization, with protocol, etc. Well, I'm no different. And the real motivation were my patients, patients like Ruth. I'm going to get choked up when I talk about her, I'm sorry. Ruth was a head and neck cancer patient, and she came to me from St. Elsewhere. That happens often when you're in a tertiary care environment. And she had had mandibular cancer, multiple resections, and she was peg tube dependent. And she came with a file this long, huge chart, and she had multiple video fluoroscopic exams. Every one of them had a checklist, but every one that I looked at, I had no idea what was wrong with her swallowing. And she, like many patients, came to us that way, and I had to do yet another video fluoroscopic exam to get any clinical yield in order to target my treatment. So thank you, Ruth, and all my patients who really motivated this trial. We have great measures in terms of swallowing physiology, all really directed at very specific questions, used brilliantly in research. I think you'll all realize that, unfortunately, they haven't been broadly applied in clinical practice. In fact, until I started teaching clinicians over the past couple of years, I really didn't even recognize how poorly some of these exams are executed, and that the primary thinking behind doing a video fluoroscopic exam by many people is to determine whether they penetrate or aspirate and give them every kind of texture that they get on their tray. And enough is kind of enough. So what do? As a clinician, scientist, and academic clinician, you shut the door, you roll up your sleeves, you say goodbye to your family and friends, and you write a grant for the next 2 months, which is what I did. This work is really supported by some things in current practice. Joy mentioned some of these. Carol Clancy presented at ASHA's healthcare conference and said, variations and inequities in clinical care, uncertainties about best practices, difficulties translating scientific advances into actual clinical practice, and useful information has been a real barrier to our moving forward. This is Agency for Healthcare Research and Quality. AHRQ also says that evidence rather than opinion, I've always done it this way, should guide clinical decision making. This work is now based on 8 years of applied research, ongoing field testing, and I thank the now nearly 1,400 clinicians who are teaching me about how to apply this clinically. Also told that research priorities should be guided in part by public health need. We don't even know what the incidence of dysphagia is because we don't have central repositories of information to give us that information. And that's why it's hard to get funded in this area, one reason. According to AHRQ, what do we need to standardize? They say, I didn't say, the instrument, your data collection protocol, your analysis method, and your reporting. We also have tried, as we strategize, and I really thought this out back in 2003, believe it or not, that whatever we came up with at the end of the day had to be a method that would facilitate easy and reliable and objective reporting. AHRQ also says that we need to look at a broader range of patient outcomes. Here again, you've heard it over and over again, not just aspiration and penetration. It's very important information. It's one piece of information, as Dr. Robbins mentioned. We use the PA scale with every single exam. It's different information. That is skewed when you look at overall impairment. If all you look at is penetration aspiration, you'll miss 2/3 of the patients that you can help with physiologic impairment. We've shown that in 2 publications. Whatever we came up with at the end of the day, me being a clinician at heart, whatever it was had to be valid in terms of its content, its construct, and its external validity. It had to be reliable. I can create beautiful measures, interval scales that no one can reproduce. They're meaningless. And when you have clinicians across this country and other countries that aren't even recording their exam, we can't expect them to adapt, at least yet, elaborate measurement methods. It had to be physiologic-based, not symptom-based. Dr. Jones talked about symptoms and signs beautifully this morning. It had to be clinically practical, and it had to be linked to clinical action. You've heard that over and over again. If it doesn't, Dr. Logeman said, if it doesn't tell you about treatment, if you don't impart your treatment during your exam, it's really quite a meaningless procedure. So it has to help you target your therapy. So I developed a structural model. For those of you who are familiar with structural equation modeling, we developed a measurement model that we tested. I'm not going to go through all this. You can read the papers if you're interested. And we looked at the model's validity in terms of relationship of measures to external indicators of health and well-being. These wonderful people in this slide gave up 8 hours of their day in 2004, came to Charleston and let me present an evidence-based review of the literature from 1956 forward about all the components of the swallow mechanism that people said were important to look at. And we agreed after 8 hours the components that I should then test during this grant. Not only did we agree on the components, we agreed on an operational scoring system. That was the first Charleston Swallowing Conference, by the way. Thank you all, faculty. We came up with these components. Some I didn't really want in there, but I listened to my panel, and we thought we would just test it, and I'm glad I listened to them. It is a Likert-type scale of unambiguous variance of each component. You're looking at a patient who has many issues, but if you can target tongue-based retraction, I think you'll agree with me. If you look at this scale, that a 3, a wide column of contrast or error between the tongue base and pharyngeal wall captures that particular physiologic impairment. In fact, at our rounds, our interdisciplinary rounds every week, when we say tongue-based retraction is a 3, we all know exactly what that looks like. When we say PE segment opening is a 2, we know exactly what that looks like. So it's really helped us in our own practice a great deal. Once we had the measures and the operational definitions, we had to put it to the ultimate test of reliability. And I can tell you that beautiful scale you see here with equal appearing scores for every single component no longer exists, because we demonstrated that clinicians' eyes cannot visually discriminate between some of these variations in impairment. So we modified the scale as part of data reduction in tool development. We used a standardized protocol. You've all heard about this today. We chose these methods. We chose these because these were in the literature. These were Dr. Logeman and many people with her have demonstrated the physiologic effects of bolus volume and viscosity. And Dr. Logeman and Dr. Robbins had just finished all their work with Veribar and standardizing those viscosities, so I had them available to me to use in this trial. We also built into the scoring system, if we couldn't give a certain texture because of safety, we built that into the scoring system. Then what we did is once we had a reliable metric, we tested it on 350 patients, heterogeneous patients from 2 facilities, one a medical university, one a community-based hospital. We subjected all the measures to confirmatory factor analysis and got 3 functional domains that remained and 17 components. We tested the external and continue to test the external validity. We looked at the relationship of our scores to the PAS, clearly significant relationship. But again, if you look at overall impairment score and you look at PA scale, the PA scale only explained 4 to 5% of the variation in overall impairment. Again, just data supporting the same thing. Both important, both complementary, both necessary. We found statistically significant yet clinically modest correlations with indicators of nutrition and quality of life, and I won't go into all of that. We also found relationships between scores, feeding tube scores, and diet grade, etc. And that's all in this first publication. So here's the tool, and I knew that if we were going to do this, I teach a lot, that I needed to be able to have materials, that were visual. And so what we did was for every single video clip that showed variant in score, there are 77 of them, I wanted a real-life physiologic animation of that component and that variant of that component. They told me it would take us 90 days to do the normal. It took me 4 months. And so this has taken a long time. But the visual information was very important in instructing clinicians to be reliable. Okay, forward, maybe? There we go. I have to go back. And we also have 2 AP components, so we visualize them in the AP dimension. And this is an online training module. Some of you might be familiar with it. I won't get into all of that. But we also, again, reliability is extremely important. There we go. And so what we do is we, once a clinician practices and learns this method of making objective measures of swallow physiology, they're trained, and then they take a reliability test so that we know at least basically what their reliability is. All reach 80% criterion. Once they're reliable, they can enter their scores into a de-identified registry that will at one point be available to any clinician who will want to go in and do research on a dysphagia registry. We're not there yet. The only ones that have access are the individual users, and we have several large health systems now who are using this method across their system. We have an automated report that is generated, that's editable, and the main components that we feel are essential features of reporting are embedded. They can be edited, but you can't leave out the essentials. This is a new feature where we illustrate the actual component score on an illustration of the upper aerodigestive tract to at least demonstrate to readers that we have a very systematic approach to what we're doing. We now have 1,400 enrollees to date in 49 states, 7 Canadian provinces, 12 countries. And I'm most happy that 915 students have enrolled in this training. And they're learning a standardized way to look at this mechanism and not just aspiration and penetration. Again, it's not the here-all, end-all. It wasn't meant to set the world on fire. It was meant to at least make a difference. The other thing we've looked at is the clinical practicality, as I've mentioned, and that this had to be linked to clinical action. We've talked a lot about radiation safety. This particular article has not been mentioned this morning. Dr. Heather Bonilla, Dr. Huda has been mentioned by Dr. Lefton-Greif. Both at MUSC did a fabulous study with Kate Humphreys where they looked at 670 swallow studies using a standardized approach, including compensatory strategies and postures. And we found that our average fluoroscopy time, which is a surrogate for exposure, is only 2.89 minutes. So evidence to present to administrators, this is a safe method. We've also looked at standardization of fluoroscopy settings. We haven't talked about that too much today, a little bit. Pulse rate, Heather Bonilla again, Walter Huda and myself have a very elaborate study proposed, looks good in terms of review so far, who knows, sequester, whatever, where we're actually looking at the impact of pulse rate on judgments of fluoroscopy and exposure to clinician. We can quantify bolus effects using the scoring schema. If I get my hand to work. So here you'll see pharyngeal stripping wave if you follow the circle. This is actually a score of 2 absent. If you go to the next one, you ask the patient to exert effort and give them a viscous bolus. You change their score from a 2 to a 0, which is normal in the context of the exam. And I need to quit here. We can quantify compensatory postures, targeted outcomes. We can map score over time and demonstrate improvement and change, why things don't change. And lastly, some external validation that we're doing with manometry. We have looked at associations between oral impairment and esophageal clearance, which is all we look at on an MBS. We don't look at stricture, we don't look at this, that, we don't do structural abnormalities. We're looking at the influence of esophageal clearance on the oropharyngeal mechanism. This was published by Jessica Gulong, a wonderful otolaryngology resident in Archives of Otolaryngology Head and Neck Surgery this year. She looked at the relationship between MBS Iymp component 17 and impedance manometry and found great sensitivity and moderate specificity has already been found by Dr. Alan Belafsky and Leonard, sorry. And lastly, Dr. Beni's also done a project where she's looking at lesion localization and score to be able to predict change over time. And lastly, my wonderful colleague, Maureen Lefton-Greif, has taught me more about babies than I ever thought I would know, where we're trying to adapt a standardized method of observing and quantifying video fluoroscopic physiologic data in babies. So thank you. I'm done.
I have a growing concern about clinicians, and I see it once a month, once a week, who say to a patient, you are penetrating and you are at risk, so you can't eat. Penetration is normal phenomena, folks. You're all doing it. It gets more frequent with age, and what shocked me in an article we have that matches Joanne's data, at age 50, you start doing it on pudding, not just on liquids. So I want to know from this panel, would you stop someone from eating because they penetrate and they don't aspirate? For me, I have to see them aspirate, and I'll do everything I can to see it, but I will not stop them from eating because they're normal. So just look at each other, because tomorrow you'll all be told not to eat. Bugs me.
Dr. Logeman, I absolutely, totally agree. Kendria Fote is a doctoral student right now, and she's run 157 normals because we're trying to look at range of behavior on this particular tool in healthy, non-dysphagic adults. And I just have to turn my head when I go in, because I don't want to bias myself by looking at her data, but I have been quite surprised at how much we're seeing, even younger than 50. So we don't have the data analyzed, but I definitely, if there's someone who penetrates and does not aspirate, clearly, I say hooray, keep going.
Yeah.
Yeah, I think we have a tendency now, we have better tools and imaging methods, and we have a real ability to overtreat. which is giving patients or people problems they don't really have. So I think it's very important to have norms related to penetration and understand what that means. We do not treat patients who penetrate as though they are dysphagic because we have enough data to know that this is part of the normal aging process. And we talk about the aging process as healthy aging. It's normal for that age group. How older people swallow with more frequency of penetration of the laryngeal vestibule is not necessarily normal for 20-year-olds, but it is a healthy 60-year-old swallow. And why we get these normative data are so we can use them in order to improve practice. And practice sometimes is giving someone a tip who penetrates perhaps at 70 and say, you know, if this bothers you, if you sense it, and people don't often sense it, but if you do, we could give them a chin tuck or something very
Benign.
non-invasive and relatively easy to put in place. But I think we have to be extremely cautious about over-treating because aging is in healthy people does change the swallow, and that's a healthy old swallow with penetration.
I think based on our experience, also penetration is probably the least reliable aspect to judge, and what's more important is the residue after the swallow rather than the penetration during the swallow.
Yeah, just one other thing. You know, the goal for every patient is oral eating by whatever means we can come up with. So I think it's important to, again, identify the potential and also the risks. And we also can't forget, you have to take the patient into consideration here. If you see somebody who has extremely fragile pulmonary health, our recommendations may differ for that patient. So that's another really important factor to consider. That's why clinical evaluations going along with our fluoro studies are so important.
Well, I just wanted to ask that question because I know we have a variable experience among this audience, and I see too many patients with no history of pneumonia, no progressive disease, which is another issue to consider when it comes to penetration in a year from when you look at them. But I see too many saying, oh, you penetrate, oh my. Well, folks, as I said, we all do it. So I'll stop. Thank you.
Jerry Logan.
Thank you. Dr. Daniels?
Really nice panel. Thank you all for that great information. Bonnie, I think your work, well, I know your work has really just expanded what us as clinicians and researchers are thinking about what we've been doing over the years, but just finally quantifying it, making it more standardized. So really appreciate that. And in developing the MBS impression, you know, you talked about in your opening statements mentioned not having a protocol where we give every known viscosity, you know, volume that a person can swallow. We have to extrapolate, you know, on a limited number of swallows. But based on that, how did you determine to do nectars and honeys when we think of them, or I think of them, as purely compensation?
Right, because when we did the original study, we figured we had to test everything that was used clinically, and that's why we included it. One thing I didn't say up there, and I meant to, is that a standardized protocol does not impart inflexibility. So even when we're using the MBS Iymp, you can modify the protocol and still make the score. So that we kept them in there, and the other reason why is because we do see, I never thought I would believe it, but we're seeing some changes in the physiologic behavior in response to some of these textures I wouldn't have thought before in the research lab. So I haven't taken them out, but when I teach the course, clearly it is to be used in a reasonable way. But I don't want people, Stephanie, I'll tell you the truth, chicken patties with barium made every day in the kitchen bread sandwiches with this is not uncommon. So if we can at least give them a standard set, it doesn't mean you have to give them everything in the set. So that's the explanation. Thank you.
Thank you. Coach Takahashi, oral surgeon from Tokyo, Showa University. And Bonnie's image is very good for me because you evaluate lip closure. And in Japan, many dentists participate in the management of dysphagia, including me.
Right.
And so we DDS focus on oral transit or mastication,
Yes.
lip closure. And this morning, many authorities showed many video fluoroscopic image, but without lip or part of oral appliance is gone. So this is looked strange for me. Just comment. Thank you.
Thank you very much. Well, we're glad you do what you do, so thank you.
Hey, Kate Hutchison from MD Anderson in Houston. My question is for Dr. Robbins regarding the penetration aspiration scale. We use it and we rate each discrete swallow. And I think that the question that we run up against when we then summarize it either in our clinical report, but even more for our statistical analysis, is the appropriate way to take your summary score. So, we, for instance, take the worst of the impairment and then report on the median of that. And what does that mean when you relate that to another research group that's providing me their mean score? So any comments or insights on the appropriate way for a single summary penetration aspiration rating?
Yeah, I think a mean score is pretty misleading.
Correct. Yeah.
And if we're trying to determine how to treat a patient, I think knowing the worst swallow is very important. So I agree with what you're doing, and that's what we recommend to folks. But I think knowing the range of the performance is also important. So if you give the range, you will have the worst score and the best score. So that's often what we'll report.
I would even
Yeah,
add
please.
the range and the distribution and the frequency of the it's a whole
But
big
the
thing.
distribution
not-
is so dependent on your number of trials, right?
Exactly. Yeah, someone was talking about this earlier, the patient aspirated 3 times. Well, 3 out of how many of what?
Right.
So I think it needs to be looked at, the gestalt of the swallow study needs to be looked at, not just the best, the worst, or some measure of central tendency.
Well, and of what they're swallowing.
And, yeah,
Right.
across the conditions. Yeah.
Thanks.
Thank you. One more question, and then I have an announcement, so don't leave.
I just would like to comment on normal individuals who penetrate. I want to congratulate to all the standards, but would like also to state that we can see event-related aspiration as well. As a child falls on the floor and stands up, will not be sent to the orthopedics. We may find also young people who aspirate but doesn't have oropharyngeal disease. So we all should really be very careful by analyzing also the situation when maybe aspiration occurs in only one swallow.
Yeah, all of the variables that go into it.
And that's what we found, remember, in our normals, so to speak, we found older normals will have deeper airway invasion than the younger normals do. And this is important to take in consideration. In addition, we found that their worst scores as the older group wasn't their first swallow in the series, nor their second swallow. As they had more swallows, up to 5, the score got worse. So we always think that older people fatigue, and we now know about sarcopenia and endurance and all sorts of related variables, and I think that was evidenced in the penetration aspiration scale findings. Thank you for your comments.
I'd be really interested to see it someday, how some of these measures, how predictive they are of long-term adverse outcomes. That's the real.
We're doing it.
Yeah, you want to do that?
We are doing it.
Yeah, we are doing
You'll
it.
hear
I mean,
about it tomorrow.
That's really the bottom line, because if we're looking, as Dr. Logeman was suggesting and others,
Yeah.
if we're looking at the minutia of swallowing in the context of a patient's health and medical conditions, we're missing the boat completely in terms of their long-term risk and shortening of life because of dysphagia. So.
That's right.
Okay, thank you very much for this wonderful panel. Before you go, this concludes our morning presentations. Lunch is on your own. There are various restaurants in the area throughout downtown Seattle, as well as the hotel restaurant, the Georgian. For a list of suggested restaurants, I feel like Ryan Seacrest here, please visit the information table located outside the ballroom door on the right. We look forward to seeing you back here at 2:15. They're going to start right on time for the second half. Thank you.